We have with us eminent lecturer from United Kingdom, Dr. Ammar Hourani, who will be talking about the irrigation in endodontic therapy. So let me briefly introduce Dr. Ammar, then he will be starting the webinar. Dr. Ammar Hourani is a consultant, a specialist in endodontics, and he is a clinical lecturer at Peninsula Dental School, University of Plymouth, United Kingdom. He graduated from University of Glasgow in 2009, and he gained his MFDS RCS in Edinburgh in 2012, a diploma in clinical education, Royal College of RCPS, Glasgow in 2014, and the membership in Endodontics, RCS, Edinburgh in 2019. And a year later, he obtained a doctorate in dental sciences in endodontology from the University of Glasgow. So as you can see, he is very much into endodontics, and a field which I believe all our colleagues are interested, because presently the situation is somewhat tricky in this COVID era, how we practice endodontology. And his doctorate was based, or rather is based on his study of the effects of orthodontic treatment on traumatized teeth, a systemic review and weakness study. And even though he is a specialist endodontist, he has a wide range in experience in restorative dentistry, oral and maxillofacial surgery, and oral medicine, to name a few. So I'm sure the participants who have, or rather postgraduates as well as consultants who are joining in from other fields, if you have any other questions pertaining to that fields, along with what he's talking about, you can always forward your questions at the end of the lecture. So I would like to state that during the lecture, your mics are muted. So if you have any questions, please type in your questions. We'll be taking in the questions at the end of the lecture, so that it will not be a disruption or an interruption to the lecturer. And we'll be forwarding the questions at the end of the lecture. So without taking too much of time, I would like to invite Dr. Ammar to give his lecture on irrigation and its importance in endodontic therapy. Over to you, Dr. Ammar.
Thank you so much for your introduction. Thank you for the Sri Lankan Dental Association, Commonwealth Dental Association, for inviting me this evening. Hopefully, I'm going to do a run through of irrigation and endodontics, and this will be a presentation that will encompass quite a lot of the current evidence base in this subject matter. Hopefully, it won't be too heavy, and I'll keep you guys all awake, because it can be quite a long subject, and sometimes it can be quite a dry subject, but hopefully it'll be as interesting as it can be. If you have any questions, please do let me know at the very end. Without further ado, I'll start the presentation. So as we know, if we go to the very basics, that microbial infections are the cause of apical periodontitis. Treatment largely focuses on reducing the bacterial load from the root canal system, and in doing so, you can then allow some periapical healing to take place. So it's all about reducing the bacterial load to a point where the body can actually deal with the infection at hand. Now, this is achieved through two elements. One, through enlarging the root canal system with mechanical instrumentation, and then using irrigants as the antimicrobial effect within this equation. Now, this is what we're dealing with on a day-to-day basis. We're dealing with dentine that's heavily infected with a wider range of microbial infections, and especially the biofilm. The biofilm is extremely difficult to break down. The other problem that we have is you've got the dentine tubules, and within which a lot of these bacteria can also colonize and live, some of which can actually live in the lowest of pHs. They can live in the most challenging environments. They're sort of Spartan bugs in that respect, and therefore they're much more difficult to get rid of. And this is another slice of what we're dealing with. With a periapical infection, you have biofilms that are scouring the apical third of the root canal system. This is a very difficult area to clean for a number of reasons, which we'll touch on in a moment. But this area has 98% of all the lateral canals and ramifications. And that's why when we do apical surgery, this is the part we usually have to remove, because this area is extremely difficult to clean. And therefore, this is areas where you can have recanalization of the microbiota, as well as having extra oral biofilm that even root canal treatment within treatment that we're doing within the canal may not be able to get rid of. And therefore, we are really hoping that the antimicrobial effects of the irrigants that we use, as well as the body, can actually clean up the rest of the stuff that's outside the root canal system. Now, the roots of bacterial entry, as we know, is a number of causes, the biggest of which is caries, which is the most prominent disease probably on the planet. Second of which is restorative procedures. So when we're doing any crown preparations, deep fillings, the actual restorative procedure itself may in itself cause trauma and damage to the pulp. And that could be from a number of reasons, from having open dentin tubules to the thermal stimulation or increased in temperature that the cutting efficiency of the burrs are causing to the pulp, and they're causing localized trauma. Periodontal pocketing and therapy. So if you've got deep pockets and the patient's had some sort of RSI, sorry, they can cause, post-operative sensitivity, and some of which is removal of the dead and dying cementum, which may open up lateral canals and dentin tubules deeper down in the periodontal ligament space, which is in communication with the root canal system. Attrition and abrasion, as we know, in 13% of cases of severe tooth wear, we can get pulp necrosis. If we have a big infection, which is usually quite a large cystic lesion, it's spread over time and enlarge, causing damage to the adjacent apical biology of the adjacent teeth, causing it to die through necrosis. Obviously, after trauma, you can get resorptive defects, and that can cause bacterial entry, as well as anachoresis, which was a theory in which if you had an infection somewhere else in your body, it can go through your bloodstream and then enter a tooth's pulp chamber through the neurovascular bundles. Now, this has never been proven, but it was a theory that was discussed many, many years ago. But again, this is probably not a cause for this, or it has not been proven to date. Now, indications for root canal therapy is caries removal involving the pulp, where you have pain or swelling, so irreversible pulpitis and what precedes thereafter. Trauma, after trauma, you may have high likelihood of pulp necrosis, depending on the type of trauma and the severity of trauma. And this may require root canal treatment to prevent resorption, not only just to get rid of the infective process. Cracked teeth may cause bacterial ingregation into the tooth, causing severe sensitivity as one of the signs and symptoms, as well as pulp necrosis over time. Root resorption and elective root canal therapy, where the prosthodontist may need to go into the pulp chamber to create space for the prosthesis. And this is something that we try not to elect to do often, but sometimes this is something that we may need to do. So the purpose of root canal therapy, really, in a nutshell, is to try to remove the inflammatory tissue within the root canal system. And in doing so, if you have irreversible pulpitis in which the microbial infection is in the coronal pulp chamber, you want that to be removed before it actually enters the radicular pulp, causing periapical periodontitis. And that's why we have the high success rate in vital cases, such as irreversible pulpitis. And if we have a periapical infection that's already present, then the plan really is to get to the root canal system, try to clean out as best as we possibly can, reduce the bacterial load, and in doing so, tilting the balance towards healing of the body, just to clean up what's in the periapical tissue. Now, we need to be careful when we're consenting patients that once we have a periapical lesion that's developed, we already have a reduced success rate because we have no control over the body's immune response, and we've got no control over healing. So therefore, we need to be careful when we're doing these cases that we let the patients know that this is a treatment that's going to be carried out over either 1 or 2 visits. And it may take, anywhere between 6 to 12 months to heal, if not much, much longer. And there's always a likelihood that after 12 months, if it hasn't healed, there's a high likelihood it may not heal. So that's why in Europe, we follow the European Society of Endodontics guideline, where we review large lesions at 6 months, at 12 months, and then yearly for up to 4 years. And anything after 4 years is deemed through the European Society of Endodontics guideline as being unfavorable. It's unlikely for it to heal. And then we keep an eye on it. If a lesion gets bigger, then we need to inform the patient and may need to do another root canal treatment and or apical surgery and or an extraction. And if the lesion is getting smaller, is exactly the same in size or just slightly diminished in size, then we need to let the patient know that there is a high likelihood, that the tooth is surviving, but it hasn't succeeded. So therefore, we have to make sure that we get rid of peripheral tissue. Sorry about that. So endodontic success really can only occur once we have a number of things that work in unison with each other. So getting good access cavity and straight line access, locating all the canals, gaining patency in the root canal system, which improves our outcome by doubling it, making sure that we get irrigants in there in the root canal system to clean out any bacteria that's on the biofilm, removing as much of the biofilm as possible, removing the smear layer that's developed as a result of mechanical preparation, and then having a good coronal seal. And as long as we have a good coronal seal, which improves our outcome by 11 folds, and we have patency as well as irrigating to as close to the apical third as possible, we should hopefully have a relatively good outcome in the long term. And really, it's a balancing act between mechanical preparation and irrigation. We don't want to over prepare the root canal system because then you remove too much dentine, you over weaken potentially the tooth structure that you've got, but at the same time, you don't want it to be too small a preparation so that you can't get irrigants in there. So it's a fine balancing act between how much we want to remove in the root canal system and how, and how we can actually get the irrigant as close to the apical third as possible. Now, the challenges in root canal irrigation is a number of challenges. I think someone's got their microphone on. Don't mind muting it. Okay. So the complexity of the root canal system is a number of things that we have. You've got the dentine tubules, you have the accessory and lateral canals within the root canal system, you've got the furcation canals within the root canal system, you've got anastomosis between the canals within the anatomy of the tooth, as well as the isthmi, which connect root canals together. You've got the apical delta, as well as curvature within the root canal system. And so therefore, the anatomy of the tooth is in itself very difficult to clean. And therefore, mechanical, root canal irrigation is going to play a massive and vital role in getting into these areas where your mechanical prep will not be able to get into. So what does mechanical preparation do for us? Well, it helps remove the vital and necrotic tissue within the root canal system. So it removes the bulk of all the material, and it creates a sufficient space for irrigation and medication of the root canal system. So mechanical preparation really does two things, really, in essence. It removes the necrotic tissue and creates space for your irrigant. That's all it's doing. The tapering effect is creating space. But we have a lot of limitations in mechanical preparation. We can't just do the mechanical preparation and not irrigate within the root canal system. And why is that? Well, because mechanical instrumentation alone cannot touch every aspect of the root canal system. We know through Peter's study that almost over 50% of the root canal system is completely untouched by mechanical preparation. The more ovoid the canal is and the more flattened the canal is, the more likely we have a greater space that's completely untouched by the root canal system. You need to remember that the mechanical preparation on all the NITI instruments that we use at the moment are creating a circle within an ovoid shape. And therefore, there's many surfaces within the canal that are completely untouched. We can't remove all the necrotic and vital tissue within the root canal system. That's just not physically possible. So therefore, again, this is another limitation of mechanical preparation. And alone, it cannot remove the sufficient amount of bacterial load within the canal. So it can remove infected dentine in the areas that the file can touch, but there's a lot of areas which are completely untouched. And the other problem is the mechanical preparation alone has minimal, if no, antimicrobial effect. So therefore, we need something adjunct to what we use with mechanical preparation to allow us to physically clean deeper into the root canal system tissue. So as I showed earlier, if you look at this slide, for example, you've got an ISO 30 file here, which is getting to the apical third. If you apically gauge this apical foramen, it's at 30, but as you can see, the file is actually floating three-dimensionally in midair. It's completely not touching anything coronal off the apical third, and therefore that's an area that's completely untouched by mechanical preparation, and that's an area where you're going to have stagnant vital tissue, stagnant necrotic tissue with bacterial biofilm that will continue to thrive and grow. So therefore, mechanical preparation, as you can see here, is unlikely to do anything for you in the long run. And again, if we look at the apical third with even the best obturation carried out and the best mechanical preparation carried out, you have isthmi between canals that cannot be cleaned. And as you can see here on this slide, there's microbial biofilm in the isthmi that we just can't physically get into within standard mechanical preparation alone. If we also look at the newer micro CT studies and CBCT studies, you can show, it shows again, if you look at these slides, this slide, the red is the areas that the file can actually prepare, and the greener areas are completely untouched. And again, this is showing us that you have a large volume of the root canal system that it cannot be prepared, cannot be cleaned sufficiently by mechanical preparation alone. And there's some studies to show that if you do mechanical preparation on its own and then you rinse the canals with saline, that your bacterial load can be reduced by up to 25%. This is very difficult to quantify this. These are all older studies. But again, it just shows us that actually this is not enough to tilt the balance towards the body to heal. Because even with saline, all you're trying to remove is the planktonic bacteria, the bacteria that's on the biofilm that isn't really touching any surfaces. It's what's in the middle of the canal within the infective soup within the root canal system that just flushes away. So this again shows that mechanical preparation alone does not get rid of these very difficult bacterial biofilms that can co-aggregate together. Nair had a lot of fantastic studies on this, and on one of his studies he showed that he did a very good root canal treatment. It just did not work, it failed. And when they took an apical size, when they did apical surgery and then looked at it under an electron microscope, you can see that there's a lot of areas, again, that are completely untouched by bacteria, by the filing and even irrigants. And therefore, this is an area where you have stagnant parts of the root canal system that is completely untouched. And this is an area that will eventually cause failure because the biofilm will regrow and its toxins will reinitiate another failure in the root canal system. So it's difficult to prepare into the apical third, it's difficult to disinfect the apical delta, and you have residual microorganisms that will result in future failure. And that is why when we do apical surgery, we remove 3 millimeters of the apical root. It's purely because of the apical ramifications and the lateral canals, which are found in, that about 98% of which are located in this specific site. So you can imagine that this is not only difficult to get to, hazardous to get to with sodium hypochlorite and the potential accident that you might cause, but also at the same time, it's impossible to get into all these areas in a 3-dimensional structure. And with mechanical preparation alone, that also has its own problems. You have increased, with increased instrumentation, you will have more mishaps if you don't clean the root canal system. You have irrigation, it prevents the irrigants getting in there. Sorry, let me just go back. If you don't debride the root canal system after night eye instrumentation, you increase instrumentation mishaps because you clog up the flutes of your night eye instruments, ending up that the file itself starts to rotate in its axis, and it may potentially fracture. It prevents irrigation getting into the dentine tubules and also into the difficult areas of 3-dimensional anatomy of the tooth, as we discussed in the root. You have residual microorganisms and biofilm. You could potentially push out all the debris through the apex, causing postoperative symptoms, and therefore this can all prevent long-term healing of a root canal treated tooth. So what's the role of an irrigant? Now, irrigants have a strong antimicrobial effect, depending on what type of irrigant you're going to use. They penetrate the dentine to an extent. They obviously don't penetrate it through the whole width and length of the dentine tubule, but they will go to a certain depth. They treat the areas that are completely untouched and by instruments alone. So they treat uninstrumented surfaces. They prevent packing of the root canal system with debris. You're constantly flushing away anything that you've shaved within the root canal system itself, and you're washing it out. And and you can remove the organic and inorganic debris within the root canal system. Again, no one irrigant will do all of this for you, and therefore we have to be careful, on what type of irrigants we're going to use and what's our protocol in irrigation, which we are going to discuss later on in the slides. Now, the ideal properties of an endodontic irrigant is it has to be bactericidal, germicidal, fungicidal. It has to act as a lubricant, and I'll explain why this is very important in a moment. It has the ability to dissolve the organic and inorganic tissue. It does not irritate the periapical tissue or affect healing. Is active in the presence of blood and exudate. It removes the smear layer, can penetrate the dentine tubules. It doesn't stain the tooth or teeth, especially on the in the aesthetic zone, and doesn't affect the mechanical properties of the tooth. It does not make it any weaker than it already is with what we're going to be doing and after examining restoration and restorability of the tooth itself. So as we said, the importance of irrigants is, we're going to recap, is that there is no irrigant that does everything for you. We don't have an irrigant at this moment in time that does everything for us. So it's not about just, using the right irrigant. It's also knowing the challenges that we're going to be dealing with, such as anatomical challenges within the tooth, the organic and inorganic components, the bacterial biofilm and its complexity, and the smear layer. So we've got a lot of things to be dealing with within the root canal system, and therefore no one irrigant can actually do all of this for us in one time. Now, the most common irrigants that we're using at the moment is sodium hypochlorite, chlorhexidine 2%, and EDTA 17%. There's other irrigants out there such as saline, HEBP, which is a material that's been designed by Zander, which has editrionic acid within it. So therefore, you could take editrionic acid and put that with the sodium hypochlorite. And again, they work synergistically together without one affecting the other's efficacy. Qmix and MTAD are things that are available, but they're not available in the UK, and it's not something that we use at this moment in time here. And we're still looking for the long-term evidence on these materials. So sodium hypochlorite is the gold standard irrigant at this moment in time. There's no such thing as a gold standard irrigant, but this is the closest material we have to it. And it's the most commonly used and commonly researched material within endodontics. It has an alkaline solution of pH 11. It's antimicrobial and bactericidal. It's very good at dissolving pulpal tissue, collagen, and organic tissue as a whole. So within the smear layer, any organic tissue is actually removed by sodium hypochlorite, and anything within the root canal system, such as vital or necrotic tissue. However, it does not remove the inorganic smear layer, the dentine shavings. It just can't remove it. It has no substantivity, such as calcium, such as chlorhexidine, and it has tissue toxicity. If that goes through the apex, we're going to have some problems. It's going to cause hypochlorite accident. However, it works very, very well with calcium hydroxide in removing remnants of vital tissue. If you look at Hasselgren's study, that's what it showed. When he used calcium hydroxide with sodium hypochlorite, the calcium hydroxide seemed to attach to more protein, and sodium hypochlorite seemed to actually be able to dissolve it much, much faster and much, much quicker. It also has a synergistic effect with EDTA in the sense that EDTA will remove the inorganic debris and the sodium hypochlorite will dissolve the organic debris. So again, smear layer cannot be removed in its whole without having sodium hypochlorite to remove the organic element within it. Now, what's the whole thing about why are we trying to lubricate the root canal system? Why is sodium hypochlorite or chlorhexidine or other things that we can use in the root canal system? Why do we need that when we're doing our mechanical preparation? Because by applying a lubricant within the root canal system, it allows the file to work itself nicely within the canals, but it also reduces applied stresses on the NiTi instrument. And how that it does that is it prevents the friction from taking place or reduces the friction. But at the same time, as the NiTi instrument is cutting into the dentine itself, it's also increasing the temperature of that file through the thermodynamic situation that it's happening within that instrument itself. And therefore, the irrigant itself acts as a coolant. It cools down or reduces the temperature of the instrument, therefore reducing the chances of that file fracturing because of overheating. So again, sodium hypochlorite, that's why when we're doing root canal treatment, always make sure you have sodium hypochlorite within the canal to act as a lubricant, to reduce the stresses applied on the NiTi instrumentation through friction, and also reduce the temperaments of the file itself. But the problem with sodium hypochlorite, as we all know, and I hope it doesn't happen to any of us, but the biggest problem is a sodium hypochlorite accident in which the sodium hypochlorite literally comes through the apex of the tooth. Now, how can we prevent this? How can we prevent sodium hypochlorites happening in our clinics? Well, we pre-bend the needles. Always make sure the needle is pre-bent 2 millimeters short of the working length that we've established. Try to use a side venting lower lock syringe. Ideally a size 27 gauge, which is about a 40K file. So therefore, you're going to be short of your apex by at least 3 to 4 millimeters. Use your index finger and not your thumb or the palm of your hand, because those two lateral objects that we just discussed are probably the most powerful muscles that you have in your hand. Your thumb and your palm of your hand have got extremely powerful muscles, and you can therefore push the irrigant through the foramen. Constantly move the needle and don't wedge it in position so that it's constantly moving. Therefore, you're not putting downward pressure off the irrigant. It can actually go sideways and back up through the tooth. Now, if a sodium hypochlorite has happened, we don't really seem to have a unified protocol. Different schools, even within the UK, have very different protocols in dealing with this. So something that I follow is dilute, information, pain control, evaluate, review, and refer. Now, in terms of dilute, irrigate, once you've got sodium hypochlorite accident in Liverpool, we did not irrigate the canal. We would dry it with, we'd let it bleed out, and then we would place paper points to dry the canal, calcium hydroxide, and we closed everything off. We did not really do the saline rinse because the worry we had was that you had sodium hypochlorite through the apex. If you pushed saline through the apex at this moment in time, you could push the sodium hypochlorite into other tissue planes, causing more problems. So although dilute is one option that some people like to do, it's something that I don't personally subscribe to based on my training. Inform the patient, tell them what's happened, give them pain control, so paracetamol, codeine, non-steroidal anti-inflammatories such as ibuprofen, plus or minus antibiotics if you think it's important. Evaluate, so check for paresthesia and anesthesia, check for swelling, submandibular or around the eye that's getting larger. If you have this, you have to refer to oral maxillofacial surgery immediately. If this has not happened, you can review the patient at 24 hours, in 2 days, in 4 days, and 1 week. And if the patient after that moment in time still has issues, then it would be a good idea to refer them to Max Fax within 7 days to examine this for you and allow the patient to have some peace of mind about what's going to happen in the future. Now, if we go back to sodium hypochlorite, can we improve the efficacy of sodium hypochlorite? Well, there seems to be evidence to suggest that this is yes, we can. So we can do that through 3 means: the time and concentration at which we use sodium hypochlorite, the temperature, and how we activate it. Now, I always get asked this question: I use 5.25 sodium hypochlorite, do I get a better outcome? Well, let's discuss the science. Sodium hypochlorite comes in percentages of 0.5 to 5.25 in the UK. In America, you can get up to 8%, I believe, and I have seen some posts that showed this. Now, a low concentration of sodium hypochlorite and a high concentration of hypochlorite are actually equally efficient at reducing the bacterial load within the root canal system. Now, sodium hypochlorite in a higher concentration seems to be more effective against much more difficult microorganisms within the root canal system, such as E. faecalis and Candida albicans in re-RCT cases. In vitro studies, test tube studies, it showed that 6% was a good irrigant to remove or destroy effectively the bacterial biofilm. The bacterial biofilm is extremely difficult to break into, and 6% sodium hypochlorite seems to show in vitro that this was possible to take place. What we're trying what evidence is showing us, however, is that if we use a high volume of sodium hypochlorite over a long period of time with frequent intervals of fresh sodium hypochlorite, then it's as effective as a lower concentration. So if we use a solution that, say, is 1% sodium hypochlorite against 5.25 sodium hypochlorite, 5.25% sodium hypochlorite may remove the bacteria and necrotic tissue within the canal within, say, let's say for argument's sake, 5 minutes, but 1% may need 20-25 minutes. And therefore, the end goal is identical. We're going to get to the same destination, but with 1%, we need to use a lot of it over a longer period of time to reach the same outcome or the same destination as 5.25, which will get there much, much sooner, much, much quicker. It's all about how much chlorine ion you have in solution. If you have the chlorine ion attaches to tissue and it becomes dissociated, it doesn't work anymore. But the balancing act here is if you want to use 5.25% and that goes through the apex, that is going to be a lot more damaging to the surrounding tissue in from the hypochlorite accident than 1%. So if you're going to do root canal treatment over a long, appointment, and you're irrigating after every file, and you're irrigating at the beginning of treatment and throughout treatment, then do you really need a high percentage? Would a lower percentage be just as effective because you're using it over a long period of time? So why do we need constant replenishment? What does the science tell us? Well, it's all about the chemistry of the sodium hypochlorite. The chlorine ion is responsible for dissolving the tissue and having the antimicrobial effect within sodium hypochlorite. However, this molecule is incredibly unstable. And once it touches organic tissue, it is consumed, it's neutralized, it doesn't do anything. So with 5.25%, you're going to have a lot more chlorine ions per ml than you are going to have in 1%. And therefore, if you use 1%, you're going to dissociate the chlorine ion very, very quickly. Within 5.25%, because you have so much more of it, you've got more of it to use. So, and we know that the penetration of sodium hypochlorite through studies has shown that it could be anywhere between 77 and 300 microns. Some studies have shown up to 800 microns, but again, there were test tube studies, so we're not sure if that is what's happening in vivo. It seems to happen in vitro, but we're not sure if it's happening in vivo, and therefore, we don't really know the penetration, how deep it's penetrating the irrigation, but it seems to be that a higher concentration seems to go a little bit deeper. Now, does temperature improve the efficacy of sodium hypochlorite? Again, the evidence should suggest that increasing the temperature of low concentration of sodium hypochlorite gives you this the efficacy of a much higher concentration. So it seems to show that if you had a 1 or 2% sodium hypochlorite solution that is increased in temperature, it seemed to dissolve the tissue much, much quicker. It seemed to have a much quicker antimicrobial effect or a better antimicrobial effect. Some studies have shown it could be up to 4 times the efficacy of a lower concentration of sodium hypochlorite when heated. But do we need to heat it? Well, one thing is that when we activate the root canal system with sonic or ultrasonic activation, you are going to heat the irrigant anyway through movement. But also at the same time, don't forget your tooth is still attached to the patient, and therefore the patient's body temperature is going to naturally heat that sodium hypochlorite up. That tooth is a basin, and therefore the sodium hypochlorite is going to naturally heat within the body or within the patient's normal body temperature. So what are the challenges as we've discussed with irrigation? Irrigation of the coronal and middle part of the root canal system is relatively quite straightforward. Once you've got a coronal flare and you've prepared the middle third, the needle will go in there quite nicely. The problem that we have, as we've discussed earlier, is how do we get our irrigant to the apical aspect of the root canal system, especially in cases where you have chronic apical periodontitis, where we know we have a biofilm across the whole width of and length of the canal and through the apex. With vital cases, it might not be such a problem, but with cases where you have chronic apical periodontitis or chronic apical abscess, which is a sinus, this is going to be a problem. We need to get as close to this as possible to be able to allow some form of antimicrobial effect to take place. Now, this is, like I said, partly due to the depth and dimensions of the root canal system, the large area of the apical root canal system, and the areas that are untouched by instrumentation, and the complex anatomy. So one way we can improve on this is by activating the root canal system, or the irrigant. And by doing that, it does a number of things for us. It heats the sodium hypochlorite to an extent and makes the sodium hypochlorite work better. It's more effective. It seems to agitate the sodium hypochlorite. It allows the irrigant to flow into areas such as the lateral canals, the accessory canals, and anastomosis. It improves the irrigation to the dentine tubules, which hopefully will improve our outcome. It allows the fluid to move within the canal and not stay dormant and stagnant. It allows us to improve the removal of organic and inorganic debris, because when you irrigate activate the irrigant, you're going to move that irrigant quite violently. And with that, any debris that's attached to the side of the walls or on the apex will start to be flushed away or disjointed or dislodged. And improves the cleanliness of the canal. It seems to show a cleaner canal, but does a cleaner canal mean that we have a better outcome? In essence, it means yes, but we don't have studies to genuinely say that, because the tooth is a 3-dimensional Swiss cheese. You can't clean all of it. We can only clean what we can see and what we can instrument. So how do we activate the irrigant? Well, and why do we need to activate it? What's the big problem? At the moment, we use side venting needles, such as 27 gauge. I use a 27 gauge in practice. I find that quite a safe needle to use. Now, the problem is when you use something like this and you don't activate the irrigant, what will happen is the irrigation, if you look at the fluid dynamic studies, the irrigant is only moving in the middle of the needle between and at the sides of the walls, there's actually no movement of irrigant whatsoever. It's a little bit like the analogy of the bathtub. Everything in the middle is moving, but on the side of the bath, the water on the sides of the bath isn't actually changing. It's just overflowing itself. And therefore, it's very difficult to clean to the apical third. And you're going to have areas where the irrigant is actually doing nothing for you. Let's just recap on different syringe diameters. So you've got 23 gauge to 31 gauge. 23 gauge is almost like a size 60K file. to 31 gauge to 25. So the most commonly used ones are 27 and 30. I'm always a little bit careful about the 30, so I don't actually push it through the apex or it gets too deep. So I use a 27 gauge, which is the size 40. It naturally will give me 3 to 4 millimeters. I'm shorter of the apex, but I know I'm going to be activating my irrigant. Therefore, I'm going to get close to the apex, or as close to the apex as I possibly can. If you look at the fluid dynamic studies, again, this proves what we were discussing earlier, is that the irrigant is moving nicely in the coronal middle third of the root canal system, but at the apical third, there's actually no movement of irrigant whatsoever. We're not getting anywhere near that area, or whatever is getting in there is drizzled in there, and then it's becoming non-active. So it's not actually doing anything for us in the long run. And we can see that also from in vitro studies, that when we are irrigating with a side venting needle, the fluid that is pushed outside the needle can only pass as much as 1 millimeter to 3 millimeters past the tip of that needle. So it's not actually moving that much forward. And therefore, you're going to have areas due to apical pressure that won't move. Okay, you're going to have areas that are completely untouched in the apical third. And this is the problem with irrigating purely with needles alone. So that's why we do ultrasonic activation, because ultrasonic activation gives us a lot of byproducts, of which is heat, which then allows us to improve the efficacy of the sodium hypochlorite. But it gives us cavitation, which is micro bubble formation. And these bubbles, as they touch the side of the walls of the canal, burst. And as they burst, they create a shearing force, which rips the biofilm off. And that's what we're trying to achieve. And we get acoustic streaming, which essentially is a fancy word for violent movement of water. That's all we're trying to do. So you violently move the irrigant and you get micro bubbling. And both of these together, hopefully, will also allow heating of the irrigant and allow some of the biofilm to be flushed away or ripped off the side of the root canal system. Now you can do this manually if but these instruments can sometimes be quite expensive. So you can do this manually through GP pumping. So whatever your working length is within the canal, whatever once you've done that and you've prepared the root canal system very well, you use your master apical cone, but make sure you hold it 3 millimeters short of your working length or your preparation length, and you move it up and down the canal 100 strokes per minute, and you have to do that 3 times per canal. And that seems to do a good job. And if you look at the studies, it seems to be quite effective. Other ways you can do is sonic activation with something like an endo activator, which you can buy from Dentsply Sirona. Or you could use ultrasonic tips. These are passive, which we call passive ultrasonic activation, PUI. And you can use either the IrriSafe tip, the Endo Ultra, or the 8 teeth ultrasonic units. These will give you movement of irrigants much, much quicker and much, much faster and more violent than you would from sonic activation. And this is what we were discussing with the GP pumping with manual activation. You use the master cone, you grab it to 3 millimeters short of the preparation length. You move the GP back and forth to about 100 strokes per minute. And it's a cheap and wonderful way of using in practice without spending a lot of money. And actually, like I said, if you look at the studies, it seems to be as effective as the other two forms that we discussed earlier. There's a little video that sort of demonstrates this. So here the root canal treatment has been, the root canal has been shaped, everything's finished. And this is basically the final irrigant. And you're just doing some GP pumping, and it's literally moving the irrigant back and forth, back and forth. And like I said, you can buy sonic and ultrasonic activators. So sonic activation is your endo activator from Dentsply Sirona. It's a very popular system in Europe, and I think in America as well, designed by Ruddle. And then you've got the endo the IrriSafe tip, which is essentially a size 10K file, but they've blunted the cutting flutes. They've just shaved them off. Or your Endo Ultra, which is a portable ultrasonic unit. And like we said, passive ultrasonic irrigation, all it does is it violently moves the fluid, meaning that the fluid sitting dormant on the side of the canal is moved, and it's moved upwards towards the coronal third of the tooth, meaning that when you irrigate, you replenish the whole system, you remove the debris, you can hopefully dislodge some of the biofilm on the sides of the root and actually freshen up the root canal irrigant within the canals. So this is a really good novel technique to actually get a really clean canal. So if we use needle irrigation alone, if you looked at these dye studies, you can see that the dye moved a little bit into the dentine tubules to an extent. But when we used passive ultrasonic irrigation, because of the violent movement of fluid, you could actually penetrate the dentine a lot deeper. Now, these are, again, in vitro studies. We're not sure if this is happening in vivo. I hope it is, but we can't be certain. And factors that improve the irrigation penetration is a number. So using a 30 gauge needle is better than a size 27 gauge needle. But again, this is questionable because if you're going to activate the irrigant, this really doesn't make much of a difference at this moment in time. Placing the irrigant as close to the apex as possible, of course, this is correct because therefore you're cleaning the apical third, which is the area that has most of the ramifications that we need to clean. Higher apical taper is better than a lower apical taper. So again, you need to be careful whether you want to go for a bigger taper, because the more taper you go for, the greater the amount of tooth substance you're going to use. There's no point doing root canal treatment on a tooth to then weaken it sufficiently that it does not survive. So we have to be careful about the restorability and using higher volume irrigation. The more irrigant we use, the better our outcome. So the take-home message is just irrigate, irrigate, irrigate. In practice, I irrigate for about 30 to 40 minutes. I use about 2 cups of sodium hypochlorite per tooth. I take my time because the preparation element does not take me long. The beauty of mechanical preparations nowadays is because the file systems are so easy to use or much simplified in its modality that we've got so much more longer to actually physically irrigate the root canal system. So the time we've saved from step back technique and K-filing, we can actually now use and utilize in irrigation. Chlorhexidine gluconate, it's a broad spectrum antimicrobial, the advantage of which you don't get the cytotoxicity as the sodium hypochlorite would have through the apex. It doesn't have the bad smell and taste. And it can be substantive for up to 6 to 12 weeks with 2% chlorhexidine. And these were through in vitro studies looked at through Al-Mohammadi's systematic review. This is actually Al-Mohammadi's systematic review is a very, very good systematic review if you want to know more about chlorhexidine. He did 2 really nice papers on this. And normally we have them in concentrations between 0.12% and 2%. However, we need to be careful that there has been some rare interactions and allergies with chlorhexidine, which unfortunately resulted in fatalities. Now, the effect demonstrates that 2% chlorhexidine as an irrigant is better than 0.12% and 0.2%. But the problem with chlorhexidine is it has no effect on the smear layer. It has no effect on the organic tissue. It just doesn't dissolve any FFA away. And therefore, as a primary irrigant, it has very limited use. And therefore, in practice, we need to be careful not to be using this irrigant because it doesn't really do very much for us. In big lesions where you have a periapical lesion as a final irrigant, possibly it may work. But otherwise, as the source or primary irrigant, it has very little effect. And if you do use it with sodium hypochlorite, you get PCA, which is a brown precipitate, which is deemed to be carcinogenic. So we need to be careful. If you're going to use them together, use the sodium hypochlorite. You have to rinse the canals very, very well with saline and then use chlorhexidine to clean the canal thereafter to prevent this interaction. Now, what's the smear layer? What's this all about? Why is this such an important element? Why do we have to talk about the smear layer? Well, any part of the root that has been instrumented or touched by an instrument will cause the formation of smear layer. And therefore, this is an area which is anywhere between 0.5 and 2 microns thick, and it clogs up the entry of the dentine tubules. It also consists of dentine, predentine, biofilm, and pulp remnants. So this is not only clogging up the dentine tubules, but it may also have infective elements within it. And it's important to remove that for a number of reasons. It allows the irrigation of the clogged up dentine tubules. It opens it all up. It allows us to clean the irrigated dentine, the infected dentine. Sometimes it prevents us from obturating to length because you will have this precipitate of dentine at the bottom of the apical third, and it weakens our bond. You're basically bonding to wet sand. It will not bond very well if you want to have a post-in core or if you want to have a bonded NIR core, for example, with composite. So how do we get rid of this? We use EDTA. It comes in 2 forms. It comes in as gel or a liquid, and it's essentially a chelating agent. It dissolves all of this away. And it acts as a very good canal lubricant. It's fantastic for sclerotic canals. And with sodium hypochlorite, it has a synergistic effect. They work beautifully together in removing the smear layer. The sodium hypochlorite removes the organic element. The EDTA removes the inorganic element. So together, they remove the smear layer in its entirety. But you need to use it for a minimum of 2 minutes for it to genuinely work well. Okay, and I usually will GP pump my EDTA so I can get it as close to the apical third as possible to actually dissolve some more of the tissue capacity as well. Now, my irrigation protocol, I follow the Zender protocol. So after I've done all my shaping and I'm finished with all my shaping, I'm constantly irrigating throughout my treatment. I use sodium hypochlorite and passive ultrasonic irrigation for 20 seconds per canal, and I'll do that 3 times per canal. Then I will use EDTA for 2 minutes. And I'll do some GP pumping. I will not use ultrasonic activation in the canal with EDTA. There has been studies to show that you can enlarge the canal by about 10%. Don't forget, EDTA will weaken the dentine, it will soften it. You use with it ultrasonic passive ultrasonic activation, you could technically cut away some of the dentine. And then my very last irrigant is sodium hypochlorite, and then I do passive ultrasonic activation for 20 seconds, and that's me done and dusted. That's when then I'll dry the canals and I'm finished. Some people like to use a final rinse of saline to deactivate the sodium hypochlorite. That's absolutely fine too. So to recap, mechanical preparation, all it does is it removes our vital and necrotic tissue, and it creates a space for our irrigant. That's why we have tapered files. Once we do that, we add the irrigant to create an antimicrobial effect within the root canal system to be able to clean the areas that we can't clean with mechanical preparation alone. Together, this gives us the chemomechanical preparation. And basically, it's an amalgamation of both these systems. We need both together for this to physically work. So mechanical preparation alone, as we discussed earlier, reduced our bacterial load by around 25%. And it showed that if we use chemomechanical preparation, it reduced our outcome by 75%. It reduced our bacterial load by 75%. Again, these are in vitro studies that showed this, but it shows a massive improvement and almost 3 times fold in reduction of bacteria. And that hopefully may be enough to tilt the balance towards the body to clean up. We are not ever going to sterilize the tooth. That's impossible. We're disinfecting the tooth to remove enough of the bacteria to allow the body to heal. Now, sometimes it's not possible just to use the irrigants to deal with the infection. Sometimes we physically need an intercanal medicament to also help us with this. Now, what does this do? What's the advantage of calcium hydroxide? It eliminates remaining bacteria, attaches onto it, and hopefully with the sodium hypochlorite gets rid of it. It reduces the inflammation. It neutralizes the LPS and endotoxins that are released from the bacteria. It acts as a barrier for entry of bacteria. It acts as a fake obturation, and it dries the wet canal. Sometimes we can't dry the canal. We cannot obturate unless the canal is dry. Sometimes you have pus or exudate that cannot allow us to obturate this canal. And like I said, it works very well, sodium hypochlorite, in removing vital tissue. But be very careful not to extrude calcium hydroxide as best as you can. And make sure that it does not happen next to vital tissues such as the mental nerve, the inferior nerve, the sinus, or anywhere else that you think it might be dangerous. So the indications for its use is weeping canals, or canals that we cannot dry, resorption to prevent, to arrest it, trauma to prevent resorption, apexification. That's an old technique now we don't use anymore because we have biodentine and MTA that does that for us. We can have almost instant apexification. Direct and indirect pulp capping. Again, we don't use calcium hydroxide as there's a lot of really nice products coming out, such as your biodentine, your MTA, and your biceramics, such as Total Fill and iRoot. Sealers in obturation. Again, I'm not a big fan of calcium hydroxide sealers. Some people are, some people are not. I'm not a big fan of them because they dissolve and they're very difficult to re-RCT. They will really clog up your canal. And if you don't have enough time, use calcium hydroxide. If you're struggling with the root canal treatment, you can't reach your objectives, use calcium hydroxide. That's the beauty of endodontics. You can close it up and evaluate it again in another day. So when to dress the canal, when you've got pus or exudate discharge, you can't dry the canal. You've got black pigmented GP or really bad malodor. The canal is obviously very, very dirty and it needs to be cleaned up and may need intercanal medicaments to really clean it a little bit further. When you have a large periapical lesion, I will usually use calcium hydroxide. I'm always worried about a flare-up because with this, a flare-up will be a facial swelling. Now, this is not so much of a problem if you have a sinus tract, because the abscess will come through the sinus. It will depressurize everything. But with some patients, they might not feel very confident that you've done a root canal treatment and you've finished it with a sinus. So therefore, I like to reassure the patient by using the calcium hydroxide, the sinus resolves, and then they feel more confident with the treatment thereafter. Also, with patients with a large lesion, sometimes the calcium hydroxide can act as a diagnostic tool. If you do a root canal treatment, you've located all the canals, you've gained patency, you've prepared it very well, and you've placed calcium hydroxide to the apical third, but then the sinus still did not resolve, then either you've missed anatomy, or you've got a very large lesion that isn't healing well, or the biggest worry that I would have is you've got a vertical root fracture. So the sinus here, if you've got sinus and you use calcium hydroxide, it can actually allow you to diagnose, or not even diagnose, but know how to plan your next move. Trauma, again, to prevent resorption, and if you don't have time. How does calcium hydroxide work? Well, calcium hydroxide works by neutralizing the inflammatory process. It's an alkaline. Inflammation is acidic. Together, you have a base reaction which neutralizes everything. It cauterizes the tissue. Because it's high pH, it will burn the tissue, preventing the weeping, and it gives calcium to the area, which then allows formation of a calcific barrier. Single versus multiple root canal treatment. What's the big deal? Is there any evidence to suggest one is better than the other? Well, there seems to be no difference in the success rate between 1 visit and 2-visit root canal treatment. However, with 1 visit, you seem to have a little bit more postoperative pain and the need for analgesia. And this was looked at by Figini's study in 2008, which is a Cochrane review, which is the highest evidence that we have at the moment in endodontics. How long do we dress for? Well, there's a lot of studies on this, but it seems to be that 2 weeks is the optimal time. It seems to reduce the bacterial load quite sufficiently. So we would usually say anywhere between 2 to 4 weeks is more than enough. And this is what you want to use, something like ultracal with an Abbey tip, which is a very fine tip. By the time you remove these are root canals that I recently did. By the time you remove this poorly obturated GP, which caused failure and poor canal seal, as you can see here on both slides, the calcium hydroxide is pretty much filling the whole length of the canal as if it's an obturation. There's a little bit of an extrusion, but I'm not so worried about this area because this is the upper tooth. There's no anatomical structures I'm worried about in this area. So we are absolutely fine. Now, there's always been this attraction with lasers in endodontics. Is there actually studies, or is there a room for lasers in endodontics? Well, in studies on the effect of lasers as an adjunctive with irrigants seem to have mixed results. There's no strong indication that lasers can replace irrigation and removal of smear layer or improve the sterilization or debridement of the root canal system. Don't forget the lasers can produce heat. High heat can cause carbonization of the dentine and will cause the PDL to become damaged and form, you stimulate external inflammatory root resorption. The other problem is all teeth have got, even the central incisor has a curve or a bend. Lasers at this moment in time cannot go around the curve, and therefore this is a difficulty for us to get them to the apical third. So again, lasers are an interesting and exciting chapter that we may be facing in the future in endodontics, but at this moment in time, I don't believe that it can improve on what we already have. Now, all of this talking on irrigants, the question is, well, does this all affect what we have within the tooth? This is a very important question. Now, it may do. You may have effects of the collagen, and it might deplete the collagen effect through the sodium hypochlorite and EDTA, the effect of the solvents, the calcium hydroxide, and the toxins, the bacterial toxins. They may all cause a change in the chemistry of the dentine. Collagen depletion is essentially the reduction of elasticity and the increased likelihood of fracture to shearing forces within the tooth. Now, as we all age, for every decade, we decrease the rigidity of our tooth becomes more rigid or becomes more brittle by about 20 megapascals. So therefore, the propagation of fracture, our own body's defense, or the way the dentine defends itself from propagation of fractures, becomes weakened. So as we age, our dentine is changing anyway, naturally. Now, if you combine irrigants such as sodium hypochlorite and EDTA, EDTA removes the inorganic element, so it will dissolve the hydroxyapatite that is sitting about, as a layer in front of the dentine tubules. Now, if you get rid of this, then the sodium hypochlorite can then dissolve the collagen, and it can just do that by up to 20 to 30 microns. This is a phenomenon known as dentine erosion, and this has been hypothesized as potentially a cause for weakening the dentine structure and the tooth structure, reducing the bond strength of the tooth, and also increasing the risk of vertical root fracture. If you can think of the apex as being a very narrow system, you've now gone in with a very large rotary system, and then you've gone in with irrigants, you may potentially form, with stresses over time, fractures at the apex that then travel up the root, and this is what causes a true vertical root fracture. Now, healthy dentine, after the removal of smear layer, is round, and it just looks perfectly halo. But when you have sodium hypochlorite being used for a long period of time after EDTA, you create this moth-eaten looking collagen and dentine tubules that have collapsed on itself. And this is what we call dentine erosion, and it will affect our bonding strength in the root canal system. What effect does calcium hydroxide have on dentine? Well, we know that the prolonged use of calcium hydroxide on dentine will affect the collagen matrix. This may make it more brittle. but this was shown to be the case in vitro studies, not in vivo studies. It has never been proven in vivo studies, in fact. It reduces the dentine fracture resistance. It increases the risk of fracture potentially. So 2 to 4 weeks is more than enough for it to actually do its job. In fact, if you look at the studies on calcium hydroxide, after 5 days, it doesn't really do very much. It starts to become inactivated. So what's the take-home message of this? There's no gold standard irrigant that is available on the market today. Chemical and mechanical preparation go hand in hand to give us the best endodontic outcome. Sodium hypochlorite is still seen as the best antimicrobial agent that we have to date. Activation aids sodium hypochlorite and allows us to disinfect the areas that can otherwise be untouched by instruments to remove vital necrotic tissue and destroy the bacterial biofilm. Constant replenishment of the irrigant over a long period of time with the aid of activation will improve your outcome. And EDTA as a penultimate rinse is very, very important to remove the smear layer and allow active irrigant sodium hypochlorite to get into dentine tubules. Thank you so much for your time this evening. I hope I haven't taken up too much of your time, and it was a whistle-stop tour of irrigation. It's a very big topic in endodontics. If anyone has any questions that they want to ask in the future, or want to see some of the cases that we do, or want to come to our future courses in the UK, which you'd be more than welcome to attend to, please follow us on the Endo Guys, and we can hopefully answer any questions you might have in the future. Thank you so much for your time.
Thank you, Ammar, for a wonderful presentation. It's very informative, especially the protocol that you are following in. I have some questions which are lined up already. Do you mind if I forward it to you?
Yeah, forward, or you can just ask the question and I'll answer it straight away.
Yeah, sir. The first question is it mandatory to use disinfect GP points by immersion in 5.25% sodium hypochlorite prior to obturation?
Yeah, this is very, very important. So it doesn't have to be in 5.25%. Don't forget that when you're taking your working length radiograph, you're going to have the GP within the root canal system that has sodium hypochlorite. So your GP is already sterilizing itself. And when you remove that GP and you put it on the bracket table, just make sure that you drizzle sodium hypochlorite over it so that it stays disinfected, because you don't want, when, as we all know, when we're doing root canal treatment, your nurse will hand you the GP, or you're going to pick up the GP. You might pick it up with your fingers. Your fingers are dirty throughout this procedure. So you don't want to do a fantastic job to then inoculate the root canal system with bacteria that was on your hands. So just put it on the, use the same master cone, put it to one side, and drizzle it with sodium hypochlorite. And that will keep everything nice and clean for you when you're wanting to obturate.
Beautiful. So the second question is, do you have any technical tips when it comes to clearing of canal dressed with calcium hydroxide, ready for the GP obturation?
Yeah, so the first thing we need to understand is calcium hydroxide, once it's in the canal three-dimensionally, it's almost impossible to remove it all. Okay, so we need to remember this. This is not possible to remove all of it. And all the studies will show us this. One really good way that you could do it is use EDTA instantly, if you wish. EDTA clumps the calcium hydroxide together and it comes out in big chunks. Mm-hmm. Then use your sodium hypochlorite and then it'll remove the rest and activate the irrigant within the canal. And that will also remove the rest of it out. Do that for, the same protocol. Do it for about 20 seconds per canal, and hopefully you'll get most of it out, okay? Whatever is left in there will not affect your outcome, because calcium hydroxide, it will not affect your outcome in the long
run. You mentioned in the lecture that you are not a fan of calcium hydroxide based sealers. Would you like to, or rather, would you care to elaborate on that fact a little?
My biggest worry with calcium hydroxide sealers is that they are difficult to do re-RCT with. So because they're setting and they attach well to the dentine tubules. The second problem that we have is that calcium hydroxide sealers they dissolve over time. So they will dissolve at the apex. You might not get an excellent apical seal because it might dissolve over its duration. And that might be areas of repercolation of fluid back into the root canal system if you have a prolonged infection. So that's why I don't like it as a sealer, but a lot of people use it and it still works. It still works very, very well. It's just my personal opinion on this.
So in your case, you're using resin-based sealers?
Correct. I'm using AH+, which is resin-based, and I'm using biceramic sealers such as Total Film.
Right. And another question is, now regarding the sodium hypochlorite accidents that you mentioned, In the dressing scenario, after you have tried to clean all the canals as much as possible, would you dress the canal with calcium hydroxide, or would you keep the canal patent?
So first thing is, don't have open drainage. Open drainage is not a good idea because that's another source of infection within the area through your saliva and foodstuffs and other things. The saliva has got over 200 to 300 different types of microorganisms. Your root canal system only has 30. So now you've inoculated the root canal system with with bacteria that you don't know what they're going to do. Okay, so try to close it. This is very important. Calcium hydroxide is going to be very, very important here. So just take some paper points, dry the canal as best you can, calcium hydroxide, and close everything off. And then, as we discussed the protocols, painkillers, warm compresses on the face to start off with. After 24 hours, then change it to cold compresses, antibiotics if it's required. NSAIDs are very important because they're anti-inflammatories. And if you think it's quite a bad reaction, please refer to MaxFax ASAP. Don't take the risk.
Okay, got it. I have run through the questions which have been forwarded to me. Anyone in the audience with any more questions, can you please forward it ASAP so that I can discuss it with Dr. Ammar. One thing that I want to ask from Ammar is, now you mentioned about the activation, ultrasonic activation. Have you come across cases where due to the frequent activation, the dentine has weakened and has resulted in fracture of the tooth?
No, I have not heard of any of this because your activation is is a very small. It's a very small, fine instrument. It doesn't cause damage to the dentine. If anything, your irrigation tip will actually end up snapping. Your tooth is much stronger than what the tip is. So in actual fact, it's the other way around. You're only going to get damage or fracture to the root if you've made a very large preparation within the root canal system. That's what's going to cause damage, not your activation. So there's no evidence, sorry.
And regarding the another question, do you always use EDTA liquid instead of the gel?
Oh, the good question. So gel is very good for stainless steel instrumentation, K-files, okay, to allow you to navigate the root canal system. My top tip is never use EDTA gel or glide with rotary or reciprocating systems because EDTA gel plus dentine shavings together create a paste. This paste clogs your flutes of your irrigant and so your flutes of your rotary system or reciprocating system. And there's a lot of studies to show that it causes fracture because the blade is now blunted. It will just rotate on itself, okay? So always use glide for K-file, stainless steel K-files if you want to use them. EDTA is essential as a liquid, as a penultimate rinse, because as the gel, it won't touch all the surfaces. It's impossible. You need the liquid to penetrate all the areas that have been instrumented or the areas that have been not instrumented to remove the smear layer as a penultimate rinse. Without it, you then have areas that will have clogged up dentine. You'll have areas where you have dentine shavings that have still got biofilm in them and vital tissue. And these are all areas where bacteria can recolonize itself. You have a substrate and a food type for other bugs. So the EDTA will remove all of that for you and give you one last choice or one last option to use sodium hypochlorite to clean away anything that's left in there. So you have a cleaner canal. And so that's why you should use the irrigant for the very final penultimate rinse, but the glide only with K-files, never with rotary instrumentation.
Got that. What are your thoughts on advanced commercial irrigation systems like Gentle Wave?
They look fantastic. They're really nice, but they're extremely expensive. And again, I mean, the concept's beautiful. I like the concept where you don't have to do much mechanical preparation. The Gentle Wave itself, through its activation, basically sucks out the tissue within the pulp. But one, in the UK, it's not licensed, I think. And secondly, it's extremely expensive as a treatment. They're about 85 to 90,000 pounds to buy the system, and they're around 100 to 150 pounds per cap for the tooth. So as a product, it's great. Commercially, it's very expensive. And is the outcome better? That doesn't show us a better long-term outcome. So unless I see a 10% swing in outcome, then I wouldn't want to invest in something that what I'm doing at the moment doesn't give me any difference. Does that make sense? I hope.
Yeah.
So it's a great concept. I love the concept, but I think at this moment in time, it's still too expensive and it's not giving me a better outcome than what I already have in my practice.
Thank you. So another question has been forwarded by our professor. Do steroids have a place in managing sodium hypochlorite accidents?
From what I understand, in the UK, dentists don't really prescribe steroids. It's not something that is given, that we can prescribe in a BNF. Steroids are good and bad, as we all know. They're good in the sense they reduce the inflammation. They're bad because they suppress your immune system. So unless you have a very big swelling, if you have a big swelling, it may come in useful just to reduce the effect of the swelling, especially if it's close to the airway or close to your eye. You don't want an increase in pressure because that can cause a lot of damage and even fatalities, okay, especially with the airway. So here, 4 to 8%, it's 4 to 8 milligrams of dexamethasone IV, I think would work, wonders for a short period of time, but under controlled medication. So in a hospital, in a MaxFax department, I think it would work. If it's a small swelling, I think it's best just to keep an eye on it in the long run. And if you're still unsure, get your MaxFax colleagues to see it. So I think steroids have a place, but it really depends on the severity of the case.
Okay. Regarding the calcium hydroxide treatment that you talked about, very large periapical lesions, would you still follow the 2 millimeter size periapical lesion rule, or would you go for another protocol?
We would usually say that a lesion that's considered to be large is anything larger than 5 millimeters in diameter. That's what some of the studies show. But again, this is subjective because what I think is a big lesion for you might be a small lesion. If you're in doubt, put the calcium hydroxide and let things settle. Okay. For me, I have a gut instinct. If I've seen a case, the tooth is pretty, infected, the lesion might not be very large, much smaller than the 5 millimeters, but it's on multiple roots. The patient's had a lot of pain. My gut instinct would say, put some calcium hydroxide, let things settle down. We can revisit this when things are better. Okay. So the calcium hydroxide, there's no rule of thumb. It's basically, if you feel that patient can benefit from this, and or you believe they may get a flare-up as a result of what's happened, or you've had difficulties in the root canal treatment, put the calcium hydroxide, let things settle. Because when this flares up, you can go back in and wash it and improve on things. If you obturate at this moment in time, then it's going to be very, very difficult to do anything. You need to go back in and de-obturate, which we all know is quite difficult. Re-RCT is not easy, okay? So you follow your gut. If your gut tells you, dress it, dress it. This is my take-home message.
Yeah, exactly.
Yeah. Okay. I think we have run through all the questions. Another question has come in. What are your thoughts on patency filing?
It's very interesting. This is a very good debate. In Western Europe, in the UK, we like the patency filing. It's an American, I think it's an American concept. Patency filing is basically the K file going through the apex by 0.5 of a millimeter, a size 10 or a size 8 K file. If you look at Engetal's studies that was done in the Eastman, she showed that patency filing improved our outcome by doubling our success. And the reason why that is, in my opinion, is because you know now that the whole canal is opened up to you to prepare. Now, in Scandinavian nations, Norway and places like this, they are not big fans of this. And I know some really prominent Italian endodontists who are very well known worldwide also don't like the concept of patency because you might be pushing things through the apex and causing an irritation to the tissue and pushing irritants into the tissue. My concept is the evidence is showing that it's a good thing. So I like to do it because it makes me feel that I can have the full length of the root canal that I can clean, and I can clean to as close to the apical third as possible. I know that I can do this. And if it shows through the studies that I can improve my outcome, then great. I will do this. I will always do what I think at this moment in time is gold standard. And at this moment in time, it shows that patency is good. Maybe in a few years' time, this might be wrong, and we will follow that then. But for now, through my training and my teaching, what I've been taught, it seems to be a good idea.
Okay, beautiful. Thank you so much, Dr. Ammar, for a wonderful presentation and an evidence-based presentation. I'm sure that a lot of the postgraduate students who have logged in would have benefited immensely from that informative presentation. On behalf of Sri Lanka Dental Association, along with Commonwealth Dental Association, I would like to thank you again for consenting for this wonderful presentation and giving us a wonderful insight regarding endodontic irrigations. So thank you so much. And I would like to hope that we would meet again with another webinar presentation like this. Thank you.
No problem at all. It'd be my pleasure. And thank you so much, guys, again, for inviting me into this very special and beautiful arrangement.
Thank you, Ammar, on behalf of the Commonwealth Dental Association for accepting our invitation and giving this webinar on behalf of the SLDA and CDA. And your evidence base was very, very impressive. Thank you.
Thank you so much, Professor. I really appreciate your kind words.
Thank you.